Welcome everyone on board. Today we will be discussing a very important topic, which is practically, like you can say that from the day one of anesthesia or up till as much as senior you become, that is the most challenging part. That how to like integrate regional anesthesia in our practice. Okay, so we will just start. Actually, unfortunately, not everyone is attending the class regularly. I had a discussion on the basic concepts about the regional anesthesia in the previous setting. I will just try to quickly just give a glance to it, and then you, if you want, you can listen to the previous session recording, which is available on YouTube. Okay, so because the most important thing, whenever you are giving a regional anesthesia, you have to find certain answers, that whether you are giving it for anesthesia or you are giving as a part just to facilitate the general anesthesia for not only for intraoperative pain management, but for post-operative pain. So this is one thing. Okay, so you have to decide whether it is for anesthesia versus analgesia. This is one question. Then you have to see that what level of blockade you require. Okay, and then you will have option. If it is only for analgesia, you will try to have motor sparing. Okay, and you can have some adjuncts add to it. Okay, and then you will be looking for the, before these are the things related to the performance, and there will be something related to the safety. Okay, so you will be avoiding any contraindication, like any sepsis, any problem related to it, any problem to anticoagulation, any enough history of any allergy to any anesthetic, this regional anesthesia, local anesthetic medication. Okay, so these are the basic things which we discussed in the last setting. So today we will be just trying to just have a look that what do you mean by lower limb blocks. This is one thing, and I will add it to a slightly different or atypical word, below the level of umbilicus. Okay, below level of umbilicus. So first of all, if someone wants to interact, just it will be more helpful and you will learn more. Okay, so don't hesitate, don't be afraid of me. I will not kill you through the laptop. Okay, so just tell me one thing. What do you think? What are the common surgeries below the level of umbilicus, in addition to the lower limb?
Hernias.
I'm sorry, hernias. Okay, which hernia?
Inguinal hernias.
Inguinal hernia, or it may be even paraumbilical. Okay, infraumbilical hernia. Okay, infraumbilical midline, and there may be diverification of recti. Okay, this is one thing. What else?
So femoral hernia and DNCs.
I'm sorry, inguinal hernia.
So DNC and femoral hernia. Femoral hernia also occurs.
DNC. Okay, what else?
Corneous gangrene infection.
You know, I think raise the hand, and one by one it will be easier. Everyone will get. So now start with Ahmed. Yes, Ahmed.
Yes, sir. Yes, sir. Corneous gangrene.
I'm sorry.
Corneous gangrene.
Fourniers gangrene.
Ji.
Okay. Just to recall me, because it slipped out of my mind. What is this Fournier's gangrene?
So basically infection of the testicles.
Okay, testicles. Okay.
Yes.
Okay. What else? Like
Testicular torsions.
Testicular torsion. You know, what mistake we are doing at the moment is that if we classify, it will be easier for us. We will not miss it. Okay. So we can just classify it is all on lower limb. Among that, it may be orthopedic fractures or corrective surgery. okay, or joint replacement, okay, joint replacement, or there may be some limb occlusions or vascular, so there may be embolectomy, okay, usually, or there if there it is becoming infective, so it may be infective, maybe in CN drainage, or it may be amputation, okay. So you can just divide it like that. And then as we were saying, actually I sent the message regarding the possible surgery related to testes. There may be orchidectomy, there may be testicular torsion, okay, and then some anal procedures like hemorrhoidectomy, fissure, okay, gyne-ops procedures like diagnostic or the therapeutic in this DNC, okay, SK stitch, okay. So now if you go like that, if you will not miss anything, then you can go to urological surgeries like, for example, endoscopic procedures like TURP, okay, and urethral stricture, okay, cystoscopy, and circumcision, okay, penile prosthesis. So why it is important? Because if you know these procedures, then you should be it will be easier for you to make a plan for their anesthesia or analgesia, okay, because we are dissecting our management in a slightly different way, that we are only focusing on one aspect, that what regional anesthesia techniques you can use for the procedures below the level of umbilicus. Of course, there will be procedures related to big procedures which will be reaching below the level of umbilicus. But usually, if, for example, if I ask you, what is the common things if you talk about anal procedures or cervical procedures or testes, okay, do you think anything common, which may be a common thing which you should never forget when you are doing these procedures, a complication which can occur here?
Bradycardia?
Yes, vagal
Visual, sir.
mediated bradycardia, okay. So for that purpose, even if you are giving general anesthesia, if you add it with some analgesia which is covering it, okay, that is not a bad idea, okay. Like you usually there is what are the options? If you we will just discuss shortly. There, one option is epidural, one option is spinal, one option is caudal, one option is saddle. What is difference between saddle and normal spinal? Yes, Sadia.
Sir, the dose is reduced like 7.5 mg of bupivacaine.
Is this the primary difference?
So that's what I know.
No, this is not
Level
the
of blockade, like in
Level
sudden
of
we used to do
Just a-
pelvic surgeries preferably.
just a second. Who is talking? Who is talking, please? Just who is speaking out?
Dr. Mahnoor.
Yes, Dr. Mahnoor. What is saddle? Saddle is actually related to horse, okay, on which we.
Yes.
So that is actually, it is you, after giving spinal, you let the patient sit for a few minutes, okay. So only the sacral nerves are blocked usually, okay. The sacral component is blocked. So that is the concept of saddle, that you are, so that will be covering the anal area, okay. Will it cover testes?
Yes.
No, sir, it won't.
Not at all, okay. It will not.
Yes, because it comes from T10.
Yes. And why it is, do you know what is the reason why it is coming from T10?
Yes, sir, because during embryonic development, testes descend from the abdomen.
Yes, okay. So that's why you remember one thing, that testes is not supplied by the sacral area. So this is very important that it is coming from high up. So we should never forget this thing. And it can can you do TURP with saddle? Yes, please.
No, sir.
Why? You are doing surgery in prostate. Okay. So the prostate supply is from the sacral area. So why not? What is the reason? Answer is correct. You cannot do it. You have to get the block up to T10. But what's the reason?
So because we introduce large quantity of the saline.
Not saline. If there will be saline, there will be a blast. Because if you are doing using cautery with the saline, there will be atomic blast. It's not saline. It's hypotonic fluids. Okay, it's glycine. So it is yes. Go ahead, please. It is what is this fluid doing? Yes, please.
Defending the bladder.
No, let her speak. Who was speaking? Yes, please. Who was speaking? Just continue, please. Yasin, I will ask next question to you.
Sir, it's concerned with the pressure?
No, it's concerned with the stretch of bladder. Okay, because urinary bladder is constantly stretched. Okay, so that is the reason you need the block up to T10. Okay, so for TURP, but traditional anesthetist, old anesthetist, they actually, practically speaking, people are giving saddle block. Okay, so but if this question is asked in the exam, you have to write T10. Okay, so this is some basic things. What about anal procedures? Anal procedure like hemorrhoid or this fissure. Okay.
Hemorrhoids के लिए सर saddle ही देगा.
Yes.
तो उनकी भी S2, 3, 4 है ना.
Yes. Yes. Actually, please try to speak in English because we have some people who are from different countries, so it will be difficult for them to understand. Okay. He said that it is sacral nerves which are being involved, so we can give saddle. Can we give caudal in adults? Yes, Dr. Yasin, please.
Sir, it will get difficult to give caudal in the adult due to ligament.
So the answer is, can you give it with the ultrasound?
Maybe yes.
Yes, theoretically you can give, but the thing is that there are some ossification, and because the dose requirement will be high. Okay, so maybe you are not able to achieve the spread if you are giving it for sacral purpose. Okay, maybe you can give it, because I have seen people practically given caudal for other purpose, because actually caudal is an epidural. Okay, caudal is an epidural, and actually theoretically it can spread if there is, so it is not a perfect absolutely not, you can give caudal, but usually it is being given in pediatric patient, and actually it is being used, ultrasound is being used. There is a sign, frog sign. I'm just trying to give you a sniff to all the things, because if you have the idea, it will be easier for you to understand. Okay, so at the moment my aim is to give you an overview that how you can. So we will just go from this anal procedure, penile procedures. Okay, so circumcision, for circumcision you can give a penile block, you can give a caudal. Okay, pudendal nerve block. Okay, so for that in detail we cannot discuss each and everything, but I'm trying to give you a concept. So caudal, you should be knowing the Armitage regime. Okay, which is a regime based, weight based, and usually you are giving 0.25% of bupivacaine. Okay, and concentration, and this is one thing, and the other thing is that toxic dose, like per kg, it is 2 mg per kg. So you will be taking consideration the weight and the toxic dose. If, for example, it is going beyond the toxic dose, because it is 0.5 to 1.5 ml or even up to 2 ml per kg. Okay, so you are using 0.25% according to the level. It is whether it is sacral, whether it is lumbar, or whether it is low thoracic. Okay, so you will be calculating the dose of, so you should be knowing the Armitage regime. So Caudal, they can ask you about the anatomy. They can the sacral cornu, you are entering it, and then shoes. You have to confirm it with the saline. Practically, people are using it with the needle, but the safer technique is cannula. Okay, so a few words about this Caudal, and now we will go towards the lower limb surgery. So what about foot surgery? Usually I will go from down to up, and then we will discuss about some of the plexuses. Okay, so just tell me one thing, what are the common foot surgeries? And then my question will be that how to achieve, okay, how to achieve the block for foot.
Raise amputation.
For example, there is amputation. Okay, there is some fracture. Okay, there is some tendon repair. Okay, so there is some incipient drainage. So what are the nerves which are required to be blocked for foot?
Saphenous, sural, superficial peroneal, deep
No,
peroneal,
just a second.
postiotibial.
Just a second. Because if you go in a different, there are two group of nerves. Now we will go to, I think it is better to do the plexuses first. Okay, but there are, one group is femoral and one group is sciatic. Okay, so what component is from femoral nerve in the foot? What component of femoral nerve you need to block in the foot? Because these are all MCQs. Okay, if some people are thinking this is for Viva, this is not for Viva. These are MCQ questions. Yes, Tayyab, you are not speaking. Yes.
Greater saphenous nerve.
Not greater saphenous nerve, saphenous nerve only.
Okay,
it is not greater. Okay, so saphenous nerve. Okay, so saphenous nerve is from the branch of femoral nerve. And another important point which you should be knowing, it is a pure sensory nerve. Okay, it's a pure sensory nerve. I request all of you to mute the mic, please. Thank you. Okay, so it is a sensory nerve. And my question is that, or do you only want to do the somebody was telling the name of the nerves? Can you who was telling the name of the nerves in the foot? Please speak again. Who was telling the nerves of the foot?
Superficial peroneal nerve, lateral plantar nerve.
Just a second, Qasim. She was speaking first, so I will get her chance again. Yes, please.
Sural, then
Okay, sural nerve.
superficial peroneal nerve,
Superficial peroneal nerve.
deep peroneal nerve,
Deep peroneal nerve.
and posterior tibial nerve.
Posterior tibial nerve. Okay, so for example, if you have a fracture in the foot, for example, would you like to discuss or ask anything to the surgeon? What thing would you ask? Would you like to ask? Because in that case, you cannot have, like, you have an option of giving ankle block. Am I right? Ankle block, you can block these nerves by 3 to 5 ml of, not 3 to 5 actually, but 2 to 3 ml of at each nerve you can block it. You can use the ultrasound, or you can use the palpatory method by checking the dorsalis pedis, and then you will give it. I will not going in the details of the technique at the moment. Okay, so this is one option. But will your plan be changed by some of the requirement by the surgeon? Yes, Qasim, now you answer. Try to answer this question. Dr. Qasim, Zahur. Will something you will
Yes,
be
sir, it can be changed.
what is that? What thing you will ask the surgeon? Yes, please think. Anyone, if you are not getting the question, please. Yes, Dunera.
Sir, if they are going to manipulate all the fingers?
No, this is not the question you should be asking. Tourniquet. Are they putting tourniquet usually or no? Okay.
Usually not, sir. They don't use tourniquet.
If they are suspecting any bleeding, they can. Or you have to ask this to surgeon, because if they are not using tourniquet, we are talking generally, not specifically for a specific procedure. Okay, we are generally talking that this should be, because if you give ankle block and then surgeon saying I have to use tourniquet, what will you do? Okay, so in that case you cannot give ankle block. Then what options you have? You have to go a slightly higher up. What option you can give? What block you can give? Yeah, if they are only doing the great toe, okay, then, or if they are doing only the little finger, will it change anything?
Individual nerve blocks we can give.
Individual nerve block. What about individual nerve block? No, but first of all, just to try to identify what is my question. My question is that if they are doing this little finger or if they are doing this thumb, is there any difference?
Block
I'm sorry.
finger.
Yes, sir. The dermatomes is different for both of them, no?
No, this is not the answer. Think logically. Yes, Sayyid Ali, Sayyid who raised the hand, please answer. Sayyid Abid.
Deep peroneal and superficial peroneal nerves.
Yes, actually answer is that, for example, if they are doing surgery here, you don't need to block saphenous nerve. So you can only give popliteal nerve block. Okay. If you are giving popliteal block, not popliteal block, you are blocking both common peroneal and tibial nerves. So if now go back, what are the branches of common peroneal nerve in foot?
Deep peroneal and
Superficial and deep peroneal nerve.
Superficial and deep peroneal nerve. Okay. And what about sural nerve? Sural nerve is branch. Huh?
tibial nerve.
Tibial nerve. Okay. So actually, the answer, this is just to understand. Of course, if you, because for example, if they are doing surgery in the foot, in the great toe, or they are in the medial side, okay, you need to block the saphenous nerve as well. If they are doing only and doing the surgery in the lateral aspect, you can only give popliteal nerve block. They are, because we are giving this scenario in that they are using tourniquet. They are just thinking that if they are using tourniquet and have to do surgery other than the medial aspect of the foot, then you can only give popliteal block. Okay. Otherwise, you need to block the saphenous nerve as well. Okay. So this is the thing we should be knowing. Is similarly, if they are doing amputation. Okay. So if they are doing amputation, for example, above knee amputation or below knee amputation, you not only have to cover the area for the surgery, you have to cover the area for tourniquet. Okay. So if, for example, they are putting the tourniquet in the thigh, so now we are going up. I will be shortly taking you to the plexus. So just try to recall what are the nerves which you need to block when you have to put tourniquet on the leg, so on the thigh. Because in the tourniquet in the leg is the same which I told you. You have to block both the sciatic nerve component and the saphenous nerve. Okay, but if you have to put it thigh, what additional you need to block?
Obturator nerve and lateral femoral cutaneous nerve.
Very good. Obturator nerve and lateral femoral cutaneous nerve of thigh. Okay, so this is the answer, because these questions maybe they can ask you in the MCQs. And if you don't have the concept, you will not be able to understand it. If you have the concept, that you can answer the questions. Okay, so for example, if they are doing TKR, okay, and or they are doing any surgery in the knee, any like arthroscopic surgery, okay, arthroscopic surgery, or they are doing TKR. So what nerves you need to block? Of course, for an anesthesia option, or we are not discussing in that way. Epidural spinal will be blocking everything. Okay, but if you want to give the analgesia, or if you want to do it purely under the peripheral nerve block, which nerves you need to block for TKR and arthroscopic surgeries? You know about this arthroscopic surgery? Like, for example, they are doing the ligament repair. Okay, sports injuries. Okay, so it is different than TKR, because TKR the age group will be older age group, but the sports injury usually it will be younger age group. It can be any age, but usually it will be the younger age group. Okay, so what nerves you need to block? Yes, please.
Obturator nerve.
Obturator nerve, I'm not sure. I don't think so that obturator nerve is giving branch in knee. I'm not sure, but femoral and sciatic both. Okay, like you have to cover both of them. If you are only giving for analgesia, you can give adductor canal block. Okay, adductor canal block, which is blocking the which nerve? Adductor canal block.
Saphenous nerve. Saphenous nerve, sir, I guess.
Okay, because some of the component will be from sciatic nerve as well, but majority component is coming from the femoral nerve. So if you are giving it only for the post-operative analgesia, you can give saphenous nerve block. Now there is one option that you are only blocking saphenous nerve block, and one option is that you are blocking femoral nerve. Okay, so if someone asks you in which condition it is better to have adductor canal rather than femoral, and what is the reason? We just shortly yes, Sayyid.
If we want early mobility of the patient,
okay,
then only saphenous nerve should be blocked, because
yes,
femoral also blocks motor.
Yes, because you understand, because if there will be quadriceps weakness, okay, if you give femoral nerve block, it will be making patient unable to ambulate, and physiotherapy, because physiotherapy is very important after this procedure, and also to prevent DVT and embolism. Okay, so these are the things for this reason, and it is also, you should also speak out this thing, that it is part of ERAS protocol. ERAS protocol, enhanced recovery after surgery protocol. We have to early ambulate. So in that case, you are giving adductor canal block, or it is called a subsartorial canal. Okay, and you are blocking the saphenous nerve here. But because it is also easy, but if, for example, if you are not doing ambulation, then it is better to give femoral nerve block, because it will be giving a superior pain relief. Okay, because sometimes whenever there is pain in the joint, the muscles above it goes into spasm, and there is also the application of the tourniquet, which can also cause pain. So if you are not doing under this ERAS protocol or early ambulation, then you can give femoral nerve block. So this is the concept about it. Okay, so now I will just I hope you are with me and you are understanding. Okay, So now we will just go to some of the things which we have discussed. So actually lumbar plexus and sacral plexus, lumbosacral plexus we are discussing. Actually there is a formula for it. I will just try to recall and I will try to tell because it is there are 2 nerves from the 3 roots, 2 from 1, 2 from 2 and 2 from 3. This is the formula. 2 from 1, 2 from 2 and 2 from 3. So I will go from down to up. So the 2 nerves which are coming from the 2 nerve roots is femoral nerve and obturator nerve. Okay. One is coming from the posterior rami of L2, L3, L4, and one is coming from the anterior rami of L2, L3, L4, obturator nerve and femoral nerve. These are coming from 3 nerve roots. Okay, this is one thing. Then 2 from 2. So one is this genitofemoral nerve and one is lateral cutaneous nerve of thigh. They are coming from one from L1, L2 and one from L2, L3. Okay. So this is, and then 2 actually in some books, iliohypogastric nerve is only from T12. Some books it is written L1 as well. Okay. So there are actually 2 nerves. One is iliohypogastric nerve and one is subcostal nerve. So both are from actually T12. Okay. So if you count like that, 2 from 1. So one is iliohypogastric nerve and one is ilioinguinal nerve. Okay. So they are supplying the upper part of this medial thigh, or in addition with the obturator nerve. Yes, you are right. So I missed it. Obturator nerve is also supplying knee joint. Okay, so that is the reason. That is another reason that when I told you that if you are giving femoral nerve block, it will give superior analgesia because it will also block the obturator nerve. Okay, so that was the thing which was in my mind, but I forgot. It slipped out of my mind. Okay. So that's the knowledge which you should be knowing. You should be knowing the muscles, muscle groups, and the innervation of the joints. If you want to understand the regional anesthesia, you should be doing this. Okay. So lateral cutaneous nerve of thigh has cutaneous innervation only. The anterior division of both femoral and obturator nerve supply hip joint, while posterior branches supply the knee joint. Okay, these are details. Anterior division of both femoral and obturator nerve supply hip joint. To be very simple, they are supplying both knee and hip joints. Okay. So lumbar plexus supply the hip joint and part of knee joint. Hence, a lumbar plexus block offers good analgesia for hip surgery, while femoral nerve block often proves inadequate for knee surgery because there are some components from the sciatic nerve. Okay, actually this is the MCQs book and I'm reading the explanation from it. Lumbar plexus block, actually, why have you ever seen anyone giving lumbar plexus block? Any one of you?
Yes, sir.
For which procedure?
It was for the replacement, total hip replacement, I believe.
Total hip replacement under lumbar plexus block.
It was for analgesia, basically.
Lumbar plexus block, it was done in a prone position.
Yeah.
Okay, because it's a block full. It may need experts, and actually it can cause bleeding. Okay, so that's why it's not a very common block to be done everywhere. Okay, so just a second. Okay, this is another important thing which can come in the TOEIC exam and in your MCQs. You should be knowing about the dermatomes. Okay, so usually this one I was telling you that this sural component is from L1, and this one is from L5 and then L4. Okay, kneecap. L3, this crease area is from L1, L2, and this area is from L3. Okay, so at inguinal ligament, it is T12, pubic area L1, anterior medial thigh L2, L3 at the medial epicondyle of femur. Okay, L4 over the medial malleolus, L5 on the dorsum of foot, S1 on the lateral aspect of the calcaneum, S2 at the midpoint of popliteal fossa, on the this back side of thigh. Okay, and then over the tuberosity of S3 will be the sacral area, S4, S5 for perineal area. Okay, actually lumbar plexus block, I have no idea. I have not read about it and I have never performed it. So I will skip it for a while because I am, it's actually because it's practically not much of the people are doing it. Okay, practically it is lumbar plexus block is at least our part of world, nobody is doing. I have never seen it actually in my life, anyone giving lumbar plexus block. Okay, so I'm just skipping it for a while, but in the exam point of view, you should be knowing that it is one of the option, and it is good for, as she was telling, the hip surgery. Okay, so okay, just a second. Just tell me one thing: what are different options to give a femoral nerve block? Actually, there are three different. Almost they are having the same thing. One is in the form of which we say 3 nerve block. What is that? Which nerves are in the 3-in-1 block? Who will tell?
Femoral, lateral cutaneous or obturator.
Femoral, lateral cutaneous, and obturator. Okay, so actually they are fascia lata and fascia iliaca, and then actually it is given in the form of fascia iliaca block. Okay, I'm sorry for the bad handwriting. It is with the fascia iliaca block. Okay, usually when we are giving it, it is spreading. Okay, but there is a little bit of difference in technique. Result is the same, either in the form of 3-in-1 block or in the form of fascia iliaca block. Okay, actually, you know, whenever they are performing, they are asking the question, what are the things which you should be knowing about performing a block? In addition to the safety, you should be knowing the volume of the drug you are giving. Okay, what is the landmark? Okay, and if you are nowadays, if you are doing with ultrasound, what is the arrangement? So what is the, how to identify the femoral nerve under ultrasound? What is the arrangement?
It's VAN, VAN.
From
The artery is medial. I think.
vein is
Remember
medial,
it.
vein, artery, nerve.
Yes.
So
Artery.
you see the collapsible vein, and then you see the artery, pulsating artery, and then you will see the lateral side, you will see the nerve. Okay, so this is one thing. Actually, for understanding this thing, and volume usually around 20 to 30 ml. Okay, and the if you are giving it for anesthesia, you have to give 0.5%. Okay. And if you are giving it for analgesia, you will give it 0.1 to 0.25%. Okay. It will not be more than 0.25% for analgesia. It's not needed. Usually, even you can come down to 0.0625%. Okay. If you want to avoid, and then you will add some adjuncts. This is this actually we discussed in our previous discussion. We are you adjuncts as fentanyl. Okay. We are using dexamethasone. Okay. We are using some like epinephrine. Okay. So dexamethasone is also to prolong the effect. Okay. And fentanyl, it is increasing the quality of block. So usually what we are giving is 0.1%. And usually, if you forget, usually 0.1%, and you are giving 10 to 20 ml per hour with 2 microgram per ml of this fentanyl. Okay. Okay. So I will suggest all of you to have a look on Nysura. If you want to learn about regional anesthesia, this is the most authentic source if you want to learn any block. Okay, just a second, because yeah, you see, where is it?
So today we're going to do femoral nerve block in a patient who is undergoing ACL
I think
ligament repair. Of course, there are many different options.
Just a second. Actually, maybe there may be a copyright issue for it. I will not play it. They will create problem. But actually, I just wanted to show you that this is a source where you can learn a lot about regional anesthesia. Of course, you know why this 2,3-chlorprocaine is used. What is the advantage for it?
Very short acting.
Very short acting. It is ester, so it is metabolized by plasma esterases. Okay, so this is one thing. What is difference between ropivacaine and bupivacaine?
They're isomers, structural, I
Yes.
think.
But what is the difference? Practically, what is the difference?
Bupivacaine has
less cardiotoxic.
Ropivacaine is less cardiotoxic, and ropivacaine is having, there is a concept of, have you heard of differential block? What is the concept of differential block?
Is it the walking epidural?
Not walking, you are right, but it is not the correct word. It is motor sparing. Okay. Yet ropivacaine causes less motor blockade than bupivacaine. Okay. So this is because motor nerves are bigger. Okay. So preferentially, if you are, because what is the reason for it? Actually, its reason is that you are giving relatively less dose of like, because it is like you can give relatively higher dose but low concentration, so you can spare the motor blockade. Okay. So anyways, you see that this is the basic concept which I was searching. You see, the slipped out of my mind. So this may be the image which you will be getting. They are here. It is they are showing this. This is artery, and here it is nerve. Okay, so you can have a look on this book. You will understand a lot because they are showing the ultrasound aspects. If you want to learn this book is there in the Google Drive link. Okay, you can have a look. This is actually I had this book, and it is soft copy was not available, so I had this. I took the pictures, I scanned whole of the book, and I put it in the folder for all of you. Okay. This is for adductor canal. Adductor canal is also called subsartorial canal or Hunter's canal. Okay. This is an aponeurotic tunnel in the mid of thigh, extending from the apex of femoral triangle to the opening of adductor magnus. These are because they can ask you in the MCQs. Adductor canal contains the superficial femoral artery and vein. Saphenous nerve is the terminal branch of the posterior division of femoral nerve. The nerve to the vastus medialis is also a branch of posterior division of femoral nerve. You should be knowing the branches, and supplies the vastus medialis and anterior anteromedial aspects of the knee capsule. Terminal branches of the posterior division of obturator nerve also present in the adductor canal. Like they are telling you what are the contents of adductor canal. Okay. And then I will tell you some words about, do you know about this short axis, long axis, and this one in plane and out of plane? Because this is the basic ultrasound knowledge which you should have. For example, if this is the ultrasound probe, okay, and for example, this is the vessel which is going. Okay, so you have put it in the direction of the vessel or the nerve. Okay, so which view it will be? Is it short axis or long axis? Yes, please. Yes, Yasin.
It's long axis.
Long axis, okay. And the other one around this is long axis, okay. So similarly, if you put the probe like this and the vein is like the vein or nerve, so this is short axis. Okay, this is one concept. Now other concept is that if the probe is like this and you are bringing the needle from this side up or down, this is in plane or out of plane? Yes, Abid. Yes, Dr. Abid.
In plane, sir.
In plane.
In
okay.
plane,
This
sir.
is in plane. So, and if you are probe is like this and you are hitting from this or from this side, it is out of plane. Okay. So what is the difference?
Yes.
If you are doing in plane or you are doing out of plane, so what is the difference? Like if I ask you that
Sir, in plane we can see the
course of the needle, you will see the needle coming like this. Okay, so you can have that. But
yes.
What is the problem with it? In awake patient, the needle has to pass for a longer path in the patient. Okay, so it will be relatively more painful. Okay, if you are going out of plane, then maybe the distance the needle is taking will be relatively shorter. Okay, so but still you can avoid this thing by modifying the plane your vision in the way that the needle is crossing minimum part, because if the patient is awake, it can create a challenge for you. Okay, so this is but for beginners it is better to have in plane. Okay, so this is a few words about like basic use of ultrasound. Actually, in this book, because I suggest all of you to have a look on this this MCQs book, which is there here. Because if you will come out of the Holy Morgan, you will come see that the world is very beautiful. So this is one book which I was telling you, and this is the book which I told you that I scanned it, because actually before I did not have the scanned copy. So I'm just showing it to you that how much time I have spent making these things for you. Before I did not have the soft copy. I had scanned the whole book of this 400 pages. Okay. This is just to show you that if someone wants to do something, anyone can do anything. Okay, so this is only that I shared it for. Then later on, I found the soft copy, so I put the soft copy as well. Okay, so in this book actually there is one chapter I will discuss some of the aspects of ultrasound as well. We will continue our discussion, and I will tell you some more aspects about it. We will have at least one more session on it. We will just discuss a few words about sciatic nerve and just a second. If you want to, yes, Abid.
Sir, I was thinking like while doing episiotomy. Can you hear me, sir?
Yes, yes.
While doing episiotomy, what good options do we have? Like mostly we do normally other than epidural, no specified epidural, like.
This is the somatic area, am I right? For episiotomy.
Yes, sir.
That area is somatic area.
Yes,
so
sir.
tell me, what will be the somatic nerves being supplying that area?
Sir, S3 basically S2 to S4, I guess the perineal
Yes, so there is a nerve block which is
area
called
basically
as
for episiotomy, if
pudendal.
I'm not wrong.
Yes, you are right. So there is a block, pudendal nerve block, which you can give at that place. Okay.
Can other than pudendal, like I have read certain articles that that they did appreciate pudendal nerve block, but they were comparing it with caudal, na? So is it like if suppose we go for caudal, is it a good option?
Again, I tell you that that this one is in adults. Sometimes it is difficult to perform. You see, pudendal nerve
It's
block.
tricky. It's a bit tricky. Yes.
You can use ultrasound. If you learn ultrasound, then it becomes easier for you. Okay. And I will just take this opportunity to tell you how to search anything you want. Just write down the question and you will find some of the answers. And the second counter question which people ask, that how we will be identified. Sir, there are so many things. So you open one thing and then second thing, and then if you find in the three things the same, it means that is the correct.
Exactly.
Okay. So please come out of Morgan,
Yes,
and you will find a very beautiful word out of this Morgan. Okay. But if you will try to learn these things from Morgan, you will never learn anything. I tell you. Okay. Because I had to plan to discuss some of the things. I'm not actually, basic sciences is very, very difficult. Very, very difficult to explain. Okay. Just tell me, anyone knows about the principle of ultrasound?
Yes, sir.
What is the principle of ultrasound? Yes.
It uses sound waves, ultrasound waves to convert into the transducer converts into some form of electrical energy that is shown on the.
No, there are
something like that.
crystals. There are crystals. Okay. Where there are
The
crystals.
piezoelectric crystals.
Electric crystals. Okay. So it is releasing the sound waves and it is reflected by different tissues in a different way. Bone will diffract differently, water will diffract differently, blood will diffract differently, and then it will come back and it will again. So there will be a difference in the wavelength which is coming back. Okay. So sorry, the difference in the frequency according to the reception. This will be converted into the image. Okay. So this is the main. And if you are using this high frequency and low frequency, so for as much as you need superficial, you will use as much as high frequency. Okay. And as much you want deep, as you need low frequency. Okay. So usually this is the one, this is actually the linear probe which we use. So it has high frequency, greatest axial resolution, more attenuation is actually you see, attenuation is the sum total of refraction, scattering and absorption, whatever is coming back. It leads to loss of clarity of the image. It can be corrected by time gain. I will have to read about it and then I will explain to it. I had a plan to discuss about ultrasound, but usually the small thing which you should be knowing, that if you are trying to use it for superficial structure, you will use high frequency, and if you are using for deep structure, it will be curve probe and it will be low frequency. This is what at the moment we will discuss. I will because I read it many years ago, around 5 years ago. I read these things. I was able to swallow them, but now I have not read them for a long time. If you people have the time, you read it from here, you will understand everything, because even at that time I had read this book when I did these diplomas, these regional anesthesia diplomas, but I have forgotten everything. So whatever, this is the baraka of teaching, that whatever things I have taught to the people, I have never forgotten, and whatever things I have never taught, I don't know, I don't recall. So think that this is so much blessing, that if you, that's why my motto is, the best way to learn is to teach. That's what I'm doing. Believe me. I say thanks to all of you who listen and who make this session happening, is that I'm learning because of you people. But unfortunately, not many people understand this thing. So I will stop here. Okay. So I will just try to, you just in the next 24 hours till we have next session, please try to understand this thing, that regional anesthesia, the basic thing is that you have to decide whether you are giving it for anesthesia versus analgesia, and think what is the nerve supply of that area. Okay. And then think anything extra which surgeon will be looking, or any complication which you should be thinking about it. Then you will make a plan. Okay. Because there will be certain factors which will modify the plan. For example, if the patient is having sepsis in the area, maybe local anesthetic will be not working, because that area is acidic, and the pKa of usual medications, local anesthetic is they want the physiological pH, like they are having basic drugs. So if there is like infection, or there is more acidic environment, they will not work. Okay. So it will not be a good option to give local anesthesia in that patient. It will not be very effective. To counteract it, you can add some bicarb, because if you are making solution a little basic, you will achieve the pK. There will be more unionized portion, and you will be able to achieve the effect of the medication quicker and in a better way. Okay. So that is the concept of adding bicarb. When you are adding this vasoconstrictor, you are not only decreasing the absorption, so the effect will be a little prolonged, and you are trying to avoid the toxicity. So this is a rationale for using vasoconstrictor. I have told these things multiple times before as well. So we will just continue. So up till now, we have just tried to get a concept, because the technique, remember one thing, what are the landmarks, what is the technique? It is not easy, difficult. It is only cramming. But if you don't have the concept, you will not able to understand. Okay. So because my whole concept of these sessions is not to give you a B, C, D, E, F, G, H. You people are very intelligent. You can do it. Okay. And or maybe this is my lacking, that I may not be able to give you a cramming points. I can give you a concept. Then it will be easy for you to cram. Okay. So that's my purpose. So we will just try to continue our discussion one more session. And in that session, we will also try to have a look on the other options, because there is one tab block which you are using for lower abdominal area, erector spiny block, quadratus lumborum block. In addition to these blocks, I have not done lumbar plexus block. I will try to have a look at it, and I will give you few points about it. But I have tried to, in this session, I've just tried to give you a basic concept of how to choose a block for lower limb. Okay. So thanks a lot, all of you. Any questions or any comments or anything you want to add? Anyone, please? Okay. So thanks all of you. So tomorrow, inshallah, we will continue our discussion from here. I will suggest you to have a look on the recording related to the regional anesthesia and local anesthesia. When I will upload this video, I will upload the link for the playlist for the previous. So if maybe sometimes, because I don't prepare, whatever I'm telling you extempore. Okay. So because that's the reason I'm able to continue the thing, because otherwise, of course, I will not be able to have a proper presentation or proper thing, because I don't have time to read. I'm not in a study mode now. Okay. So, but still I try to extract time for all of you. So my request is that try to spend time. Okay. The more you spend time in discussions, the more you learn. So I will suggest you, all of you, try to ask questions to each other. Don't be afraid of any guilt or any ego. Finish your ego. Ask questions. Ask questions. Okay. So that's how you will learn more. You have seen kids, how many questions they will ask. They will not be afraid of anything. So be like a baby. If you want to learn more, be like a baby. Okay. Thank you. Bye bye. Assalamu alaikum. No problem. I say by fun that if you want to thanks me, you have to help me. Okay. Because I don't want anything in return. Like, I'm not asking any money. I'm not asking anything from you. The only thing which I want, that you spread this message to everyone. Even you don't need to tell my name. I don't want any self projection. What will I get? I will not get. And alhamdulillah, I've got a lot. So I don't need anything like that. The only thing I want to change your mentality, because our mentality is that you will ask, sir, please guide what I have to read. Please read Morgan. Okay, sir. Thank you. And then you are struggling. You are fighting with Morgan and you are not understanding anything. Okay. And then you are getting in a negative frame of mind. Oh my God, my neurons have degenerated. I have become old. I have so many problems around me. I am the only person who is unable to understand. That XYZ holy senior has told me he only read Morgan and he passed. So these are the things which are coming on you. And then you are thinking, are you becoming mad? Are you becoming abnormal? No, you are not abnormal. The person who has asked you to study needs to rethink. Okay. Because that's not the way. Now world has totally changed. Okay. I give this example multiple times, that many things which our forefathers used to do, even if giving too much respect, we cannot do those things in our era. Okay. So now we have a lot of sources to learn. So why we are spending our time in a book which has no pattern at all? You will not find, but the things which I have discussed, you will try to find out. You will not find out. Maybe you have to spend a lot of time. Maybe you will have some headache, Panadol extra you need to eat, and then maybe you will be able to find the things. Written, everything is written, but catch me if you can. So my mentality for you people is that Try to read it from articles. That's why before I was not able to show you this screen and this and everything. So now I share the screen, and that's why how I tell you that you should be trying to find out. I will just show you before I leave that this is the link is there, and you can find in the any topic from the article folder. Okay, you will go to this article folder, and then you will have a look, and you will find anywhere. You will go to regional, for example. Okay, and then you will find. I have just tried to as much as possible. You know, I have done it myself. So it's not possible for me to have a perfect. It's not perfect, but I have just tried to make it as perfect as possible. So you will go to the lower limb blocks, and you will find each and everything. Okay. So psoas compartment block is actually the lumbar plexus block. Okay. So this is the Nisura lower limb block summary. I just try to put it here. Everything is there. It's up to you how you use it. Okay. So, and this MCQs book which I was showing you is right here. You go to the books, and then you go to the MCQs world, and then you will find the regional anesthesia MCQs, and then you will find these books. Okay. So this is how you can find these things. And I am there till Allah has given me the opportunity. I'm trying to do it, but I don't want all of you to dependent on me. So please learn. It's my request. If you want to say thanks to me, try to learn these things and try to tell to because I don't want that if I'm not there, this cause is finished. No, I want all of you to become like me. I try to help others. This is my request. If you want to thanks me, this is only thing I want from you. Okay. Thank you very much. Bye-bye.